is HealthMed. And so we had a chance to meet with the gentleman from HealthMed for a little bit and figured this would be a great presentation for the task force to just kind of see what's happening in the telemedicine space. And so with that, we have our presenters. You want to turn over to you to get started?
Great. Just going to share screen here.
Yep, sounds good.
Okay. I think it's good afternoon now. Thank you, everyone, for inviting us, Teddy and the task force and visitors. It's certainly an honor and pleasure to be here. We really have enjoyed listening to the meeting so far and all the wonderful efforts going on to connect Minnesotans businesses that and the economic and the impact that can come from it. The economic impact, whether it be employment, whether it be activities that we take for granted in running our lives that we do online, entertainment, all of it is very, very important. But if you don't have your health and you're struggling every day just to get through the day, particularly the individuals we serve who are chronically ill, very economically disadvantaged, and as such are recipients of Minnesota Medicaid assistance via what's known as a waiver, it all doesn't matter because of the struggles that they go through. But none of what we do would be possible if not for this connectivity. So we really applaud all of the efforts going on here because it absolutely wouldn't be possible if and particularly the Senator Putnam mentioned, he concurred that high correlation between those who are currently unserved or underserved and some of these challenged individuals who are at risk and really marginalized out in the community. So that's what we endeavor to do. It's a pleasure to call upon our CEO who's going to lead us. We'll have a short deck, and hopefully everyone online can see this. And this actually, we're going to be doing a demonstration on a TV. It's the actual TV we install in our clients' homes. And I hopefully through some good technology here, we're going to be able to see that remotely as well. But Steve is a little humble in this, so therefore we won't share this with you, but we're very honored to have him as our CEO. He has done a lot of healthcare disruption for a number of decades, but most notably, he's well known as the founder of the Minute Clinic. So a lot of people, I think, have heard of that. That was bought by CVS, and he was spending a lot of time on philanthropic boards and nonprofit and charitable endeavors, and really took a liking to what we were doing, and we were honored. I'm one of the founders. We were honored to have him join us on the board. Took such a liking and felt that there was such an impact here, joined our operating team as CEO. So no further ado, Steve.
Well, I'm not Ron Mendelbaum, so you can figure out who we are. Pleasure to meet you all. Thanks for having us. We're going to kind of zip through this. I think the important part is to understand what our technology is and how it works. It's easier to explain it to you by showing it to you than trying to explain it over the phone. So we'll run through that as well. What we do, what HealthyMed does, is we work specifically with counties, home care agencies, caregivers to help service Medicaid waivered population. Medicaid waivered, the simple way to think of that is sick of the sick, poor of the poor. That's who we specialize in serving. And they are presently in the United States, in Minnesota, there's 90,000 waivered clients, right? So how do we get involved with them and help bend the cost curve for them? We'll go through how we do that and then some of our results as well. So that's essentially what we do. Our technology is really gee-whizzy. It's not really gee-whizzy. You'll understand it's not gee-whizzy. But the technology alone doesn't work. You have to wrap services around that too. So we have nursing that goes to the home, and then we provide telehealth through the television for both primary care and behavioral health. We probably today do I'd say 87% of our telehealth visits are behavioral health. And with the crisis we have in the country, it's obvious why we're there. Interestingly enough, if you're on our platform, we can deliver mental health services to you in 72 hours. And I'm not even sure anyone in this room can get mental health in 72 hours, but it's a super cool way that we have built the model to be able to do that. So that's what we do. Digital divide is so important to us. Today, we service over 500 clients, patients, usable back and forth term, across the state in 34 counties. So we're both metro and rural. And rural, where do we suffer rurally? We gotta have the internet. It's the only way this platform works. And so it makes it a challenge, and why we're so interested to be here to say, hey, we can really use some help from this committee and more people understanding what we're doing and where we're going. So if you're in St. Louis County, we're there. We have probably 40 clients in St. Louis County. So that's just kind of an idea of what we have and where we are. You can go through southern Minnesota, out west, we do well. The 7-county metro area, we do well as also. So that's kind of where we sit across. But the opportunity to bring technology to these homes to allow them to do a couple things, right? To be able to watch TV. You can watch TV, you can watch whatever you want to watch, and our system runs in the background. Super interesting, right? So you can watch Hulu or Netflix or Bonanza or whatever you want to watch. Super Bowl, all of that, all of our medication reminders, all of the things that we do to help bring health equity to this population happens without that. There's no user ID. There's no password they have to remember. The TV's on, it works. That's how simple we make it. We work with a number of different agencies, as you can see here. I'm not going to spend a whole bunch of time going through there, but you'll notice that the governor's task force has even a bar here. So you guys are on that as well. We are a home and community-based provider. So DHS is kind of our boss. That's who pays us on the waivers. And simply what we've done, we spent last year at the Capitol getting legislation passed to help to help bring this to more people in the state. So we're doing those things as well. What we're really interested in is just getting the word out, and here's what we do. And if anybody in here is a caregiver for an elderly parent, I understand. So if you are, you'll come see us at the end and go, okay, how do I get this? That's private pay is coming, not till 2025, but it's coming. Right now, we focus specifically on Medicaid waiver in the state of Minnesota only. We'll open up in Iowa, actually today is when we're starting there, and we will be in other states as well. So I'm going to just jump into, here's our platform. It looks specifically just like a regular TV. We install a 50-inch Sony TV in the home, and then RPM devices to help monitor health based on the acuity level of the client that we're serving. As I said, it runs completely on its own, but I'm going to take you into what the platform looks like and run you through a couple things in there. Understand that this is the client-facing piece, and that on the back end of this, which we call our portal, is where all the medical information goes into an EMR, and then we push and pull that to clients. If you have your own primary care doc or you have a specialist, we can push and pull all that data there. So what you're going to see is the front part, because I think it's more interesting than the back end. So. Okay, so here's our home screen. Our home screen is what the client can see when they click into our portal. You'll notice the health score on the top left is based on 4 items that we track daily: vitals, medication adherence, device data, and learning. I'll go through all of those as we kind of go through this. The client also will receive medication reminders and appointment visits. We do all of that. We set up this schedule for them. They don't need to keep that. We do all that for you. So, and the bottom part here summary, and we'll talk a little bit about that in a minute. All right, medications. So when you start with Healthy Med, our nursing staff, which is our staff, comes in, we do med rec, we spend time getting you all set up on your medications. There's 3 ways you can take medications: through the pill box, blister pack, or we have an automated device from a company called Dose. And the way this works is you will get a reminder up in the top left-hand corner or top right-hand corner that it's time to take your meds. The TV will Bluetooth to the medication device. The medication device turns on. You take your med, it opens to the appropriate time, you trip it, the meds come out, which they just did, and then we mark that you've taken your meds. So we have clients that have 2 or 3 of these, we have clients that take meds 2 or 3 times a day. All of that's coordinated through our platform. The most important thing to understand about this, the state average in Minnesota for this population for medication adherence is 30%. Our medication adherence for the clients that we have on today is 63. So what I can tell you is, or what we can tell you is, if we can get you to take the right medication at the right time, you're going to feel better. Right? So that's how medication works. Medication adherence, you can look at your score, and that rolls up to your score as well. And I'll open it up for questions at the end, so I just kind of want to zip through so you can kind of see everything. Your appointments, this is where you will see what appointments you have. There's a tech visit, there's a nurse quarterly visit, and the way it works, I'll just log into, here's an upcoming appointment, quarterly nurse visit, here's who will be here. If it was time for that, our primary care visits, there's always a nurse in the home, and the doctor does telehealth. There's a big red box in the bottom right-hand corner that allows the client to start the meeting. We use cameras when we're dealing with mental health like we do. Cameras are a big problem, so it's really important that the client has the ability to turn the camera on, right? They get to pick that. The other interesting piece is that the client also decides who their care team is. That could be their case manager, it could be a family member, it could be anybody along that line. All of our telehealth works through Zoom, so it's just like a Zoom meeting. You would get a Zoom link, you'd click in, and you'd be able to sit in on this client, this is James Bond's visit, and watch everything and be able to interact with the doctor if you had questions and that as well. So both mental health and primary care, mental health visits, family members, and care team are not involved because of the private nature of those conversations. All right, our library is unique in that, whoops, we're going to watch something, which I didn't want to do that. Okay, so our library is built specifically for each client. All the videos that are in here are prescribed from nursing or clinicians. So when James looks at these videos, all of these videos are related to James's health and ways for him to be better at what he's trying to do. Let's say, for example, James is diagnosed with COPD and believes that he's going to die. We will put videos in to help him understand how you live healthy with COPD. And those are things that are in there. He doesn't have to search for them. They're put in there, and he gets credit for watching the videos. You can see the red line on the bottom, which indicates how much of that video he's watched. And stop, start, play it 10 times, however you want to do that. But he doesn't have to search for them. When he opens that page, his videos are right there for him. Messages, I'll spend 10 seconds on this. This works exactly like text messaging. So text comes in from caregiver, care provider. James can open it, he can voice the text back, or he can pull up a keyboard and respond back. Health status, we'll end here. So the way the health status works, maybe, is all of the devices that James uses are located here. So he can track any of his readings as he's gone through, so we can follow his path. And
Sorry, Steve, if you would just hit start. Sure.
nothing better when the technology guy doesn't have technology that works. So as he's talking through that, so what happens is he will get reminders that it's time to take his readings. So I've got a temperature gauge here, and you swipe that, and it will then Bluetooth up to the TV, record it in there. So we have a record of him taking that as well.
His home monitor back in.
Okay. So it'll remote back in, and then he can see his readings, either the last week, 30, or 90 days. And we, again, all this data goes into the portal on the back end into his EMR as well. So you can see the ones we have here, and it all rolls back. So let's just go into, so you can see for his blood pressure, he's taken it twice yesterday. Here's where they are. All of that relates back. Our nursing staff then is monitoring each patient as well. So when they wake up in the morning and look at their computer, they know if they need to intercede with anybody. Our total goal is to work upstream and keep this population out of the ER. That's really what we do, and challenge them to take care and command of their own health. A couple quick stats, and then I'm done, and we can open it up for questions. So, stat number 1, ED reduction for the clients that we have on our platform today, ED reductions of over 50%, which is huge. Most ED visits today, $10,000 walking in the door. And this population, we have over 82% of our clients don't have a primary care doc. They're going to the ER. And we all are paying for that. So if we can cut that in half, if you really truly want to bend the cost curve, you can actually do that with this population. Super cool. We have hospital systems in the city, I'll leave it at that, who have super utilizers that come to their ED over 25 times a year at 10 grand a go. So if we can cut that to 12 or 10 or 8, we can make a real difference. We talked about medication adherence, a couple of other things. Engagement. Healthcare talks a ton about how do we engage people. Our engagement is over 90%. And it is because for our population, the TV's usually on. And when the TV's on, we're tracking, right? So, and the last one I'll share with you, missed appointments down. Our missed appointments run about 1% because, I mean, it's pretty clear what that is. They just have to turn the TV on. It's pretty easy. But for all of our clients, they work with county case managers across the state. And the county case manager has to give services for this to happen. And then they have to renew it yearly. So county case managers review, and then do they keep those clients on our platform and our service? Our case manager renewal rate, 96%. So what we can tell you is we have, in the 4 years that we've been doing this, we've been able to change lives of a lot of people. Not quite the PC range, but we're hoping to go that far. And I think the importance of what we do is critical. The challenge becomes we get stopped by, you gotta have the internet, period. And if you're in a rural area and you're not buying Starlink, that's not happening, you have to be able to do that. We work both with T-Mobile and Xfinity and Comcast in their programs to help provide internet for these clients. And I think Is that kind of it? All right, I'll stop there and, wait, one other thing. So let's ask, does anybody have any questions? Let's start there.
No, I think this is awesome. I wish my parents would utilize this, but, so the TV's like, that comes with part of the service, I'm assuming. So what if they are like traveling? TV, they're not taking this TV with them? Is it something they can access on a laptop or a computer?
Mobile app and computer, Jan 125.
Care team, those who are supporting these individuals, can always access it from any device, but for the client themselves to be able to have it mobile enabled, as Steve says, is coming around the corner.
Mark,
Yeah, Mark you mentioned that there are areas, pockets of areas where you do it, and that lack of broadband is an issue. Is that, I mean, do you work on a county by county basis? So you say, okay, so these counties you don't work with, is it really because you've identified that they just don't have the access for that client population, or are there other things, or how does a county, if they say, okay, we have broadband now, how do they get in touch with you? What is the problem? How does that all work?
It's a great question, Mark, and I'm going to give you the number one answer in healthcare, which is it depends.
Sure.
The answer is when we go out, when our nursing staff goes out to the home, we ask the internet questions then. There are counties that we will look at and go, we can't come, we can't help you. We'd love to work with you and see if we can find a provider and light up a building or whatever we need to do that. That's one. So we work with counties, and then there are within counties, right? You have the internet works here, but it doesn't work here. So we can use mobile hotspots through T-Mobile, and we can those things as well. So it really depends on what kind of the situation we're in. And I didn't say this, but we work with our client-patient population 6 to 87. So all across the board, young and old both on the plan.
We were impacted, as imagined, negatively by the demise of the ACP subcommittee, and to the point where clients that were going to have to cancel service with us because they didn't have connectivity and they couldn't afford, and we ended up picking up that cost for them. So just as a cost of our business. We are a private for-profit corporation. We're a public benefit corporation, which means we've stated some goals in the public sphere to show that we're not just seeking a profit, but want to drive a significant public good. I think you can appreciate there's a lot of public good here, and so we're thrilled to be able to do that and move forward as a public benefit corporation. But that was a big deal. So again, if no internet, we can't serve them. But it's so important that we have internal staff that basically act like digital navigators, and like what the American Connection Corps and League for America and some of these other organizations provide. And we're seeking more help, perhaps even from the capacity grants. We're seeking more help to do that because it's a tremendous cost to us to work through the whole navigation and connectivity piece. But we have to do it because that's the only way they can have this.
Thanks for bringing up ACP. That was another question I had. Was how does that affect?
I know there's questions.
Yeah, there's a couple online, and to follow up on broadband, Brian is asking, is there bandwidth needed to run the system?
Great question. Typically, the bandwidth requirements are very low for the application. Think of this smart Google TV that we have a close partnership with Sony because of some of their technology that makes this work. But it's like a big tablet, so this is an app. The robust portal on the backside, of course, is being viewed by the care team. To operate that, 25 and 3. Okay? The most bandwidth intensive activity is the two-way when the actual video encounter. What you're seeing here is a telehealth system. It's a little nuance, but it's important to make the distinction because Minnesota Medicaid waivers do not pay for telemedicine. They will pay for a telehealth system that architects support, But if you have this system, then telemedicine can come in. Those telemedicine visits, many of which are mental behavioral health visits that Steve referenced, would never happen for this population if this system wasn't in place, because it wouldn't be cost or time effective for any of those community providers to come in that way.
And you guys have talked a lot, we've talked a lot today about shortage of workers, how do we do this? Providers are a problem, right? And when you get rural, the challenge becomes if you have 3 behavioral health visits a week and you're driving an hour each way, it becomes impossible. How we can do that through your television in your home.
I think there's a member of the task force, I'm not sure if he's online, that's involved in the non-emergency medical transport.
That Phil Stahlberger?
Yeah, is he,
No, I don't think he's on today.
Okay, but we've talked to those providers, again, huge challenge, transportation, social phobias, and then just general chronic illness, a lot of physical disabilities that give people limited mobility, so.
And another question online, does Health Med coordinate with NAMI?
Coordinate with?
NAMI, which is the National Association.
I've not heard of that. That doesn't mean, I don't think we do.
National Alliance of Mental Illness. It's a
I
national.
don't think we do.
I don't think we do, but we certainly could, and it sounds like maybe we should.
We'd be happy to look into that.
Any of the carriers offering a discount for your services?
So the answer is yes. So Comcast has Internet Essentials as their program, which lowers cost of that. We work very closely with them, but if we're in an area where they're not there, it becomes challenging because it's expensive. And how do we? So we've gone county by county and worked with the providers there, saying, okay, here's this population we're trying to help. Can you help us with that?
Yeah, we work with all the, RVIG, Midco spectrum, and hopefully, Dave, we can work with Gardenville and talk about every single county in the state, all 87 counties, and we have a list of them and how many waivered individuals there are in the county. So they're in every county, and need to know about this. There's actually a state statute that says clients who receive Medicaid benefits must have informed choice. They need to be informed of what options are available to them by which they can then perhaps put up their hand, reach out to their case managers, not as Steve mentioned, case managers at the county level. We're out here in Douglas County right now, and we're these 5 counties in this geography are part of the Horizon public health system. I think there's someone on the, speaking, is it Brianna, from the Southwest Foundation, an initiative down there. So there's a Southwest Health and Human Services. So some counties handle it their own, others have little alliances. Up in St. Louis County, there's Arrowhead. So you have several of these alliances around. We'll work with those counties' social service, of which we would appreciate any and all additional connections to. And then we also work with the health plans. So the Blue Cross, the Prime West out here, the health partners, because when someone turns 65, they become what's known as dually eligible. So they're not just on Medicaid, but also Medicare. And then those county dollars get provisioned by the health plan.
So there's one comment, and then Brianna, I'll let you just ask your question. I don't want to keep speaking for you, but one of the suggestions was collaborating with Minnesota company GrandPad might extend services to both organizations.
We've already talked to them. Have a great relationship.
Okay, and then Brianna, did you just want to jump in and ask your question?
Yes, I sure can. Hi, everybody. Thanks for the presentation. My question is, have you identified, I think you had shared, right, you understand where your waiver clients are located. Are there certain areas in the state that you feel like the county or the public health is ready to engage in this particular platform, but does not have the infrastructure in place for their clients to be able to effectively use it?
It's interesting you mentioned that, Brianna, and frankly, I think your geography may be one of those areas. We have clients in Marshall and Lyon County, but there's Pope and a number of other counties as part of the Southwest Health and Human Services Alliance, which I believe is the geography where your initiative and foundation serves. And we could be doing and should be doing a lot more there, to the point that our vision is to set up satellite offices. Right now, everything is handled out of our Twin Cities headquarters, although we have staff that's traveling. Because as Steve mentioned, a critical component of this is not just the technology is great and the connectivity is great, but you need an in-person, high-touch component to build trust and rapport, and that high-touch component cannot be tied to their clinic. It can't be tied to their health system. It needs to be dedicated to them. So our nurses and our client engagement specialists work for Healthy Bed, which means they work for the client. And we will coordinate with them. And no one has to give up their existing care team. If you've got a primary care physician, that's great. We want to augment and accentuate that. But if you don't, and you're disconnected from care, we can jump in even in a primary care capacity until we can get you back into a routine where sometimes you go to the clinic and sometimes you're able to stay home and get handled the other way.
Question.
You talked about the decreased need and the cost savings for ER visits. And it goes a little bit to the discussion about the economic impact of broadband, but do you have numbers that would show the reduced costs or how you can stretch the shortage of rural nurses and doctors through this system, kind of numbers or data?
I love the question. I spent most of last session in St. Paul trying to get that, because here's what happens, right? Our population doesn't have primary care, so there's no really medical record on them. What the record that we have on them are claims data from their ER visits. So we've been working with DHS to go, let's pick a population, give us cost of care for this population, and then we'll share with you the data that we have after. Because you're absolutely right, we can show that. Game changer, right? Problem is, there's a lot of this going on. Don't want to show you the numbers.
Well, there's healthcare too, and there's HIPAA requirements.
Well, and I call it healthcareization of it, right? So they take it, it goes like this, and it comes out, and everybody goes, yeah, right? That's part of the challenge as well. That's a good question.
Do you know statistically how much longer a service like this would keep the aging population in their home rather than moving them to assisted living? I know there are certain medical conditions that would require a more hands-on approach, but someone who just needs med reminders, appointments because of lack of transportation, they're in their rural home, or don't have the family support or network. Do you guys have numbers on that or what that might look like in the future?
We have estimates.
Sure.
And what I can tell you, we got really tired of going to county shows, putting up the platform, and people walk up and go, how much? I need this for my mom who lives in another part of the state or wants to stay in their home or. Private pay will solve that, and the cost of that will be less than a month and a half visit at an assisted living facility, basically.
Okay.
So the answer is yes. I can tell you what assisted living costs, and I can tell you what our costs are. We can do that.
You can model that and say, wow, and if we were able to extend someone's runway in the community, staying in the home where they want to be, where their family wants them to be, and where the system wants them to be, even for 1 year, let alone longer, the ROI is staggering. Let alone the society.
And I will tell you this, that we've had a number of large insurance carriers come to us and say, our long-term insurance business is getting killed, help us. And this would be a way to extend that runway a little bit, right? And everybody wins on that as well. So it's not a great answer, but it's a decent answer.
Yeah, no, that's okay.
It's new and it's innovative. We have tremendous data and data points from 40,000 engagement points, because you can imagine every time someone takes uses a Bluetooth device to take a vitals measurement. Every time they click on the platform, they use the med reminder. Those are all touch points that we have real-time visibility into. There's never been that kind of visibility, particularly for anyone, let alone for these clients who, again, all they know, as Steve says, is the retrospective data when they present. And 9 times out of 10, when they come to the emergency, here's how it goes, folks. You all intuitively understand this, but the horrific scenario I'm about to describe, and how many times over and over it repeats itself every year. Because of the poor social determinants of health, they don't call the doctor when they get sick like we might, and schedule an appointment, take off time from work. It's a hassle, but you go do it. They wait till they get really sick and start to really unwind, and then what do? They call that limousine, we know it as the ambulance. That expensive ride takes them to their primary care clinic, we know it as the emergency room. They present there, the worst place they should be, often immunologically challenged, don't need to go there, we know what that means. And because of their chronic conditions, and there's probably an empty spot in the hospital, they get admitted. There's not Oliver Stone, not saying conspiracists, there's no one is out there to do, it's just the way the system's architected. They do the requisite 5 to 7 days, then they have to leave because there's no more funding. They're not well enough to go home, so they go to a short-term rehab at a nursing home or a transitional care unit. Do a quick stint there, then they end up back home, very often sicker and more worn out than when they went in the first place. And that scenario, with tens of thousands of dollars, wasted time and heartache on the individual and family, then that repeats itself every 2 weeks, every month. And then we have a $4.2 trillion healthcare system. That's what
Right. So what kind of discounts are they offering to make this affordable to people? These big providers?
Providers?
Yeah.
It runs somewhere between $15 to $20 a month.
Okay.
So we end up paying for, because that's the only way they're going to have it, for internet for a lot of individuals. And again, we don't get reimbursed for that because, oddly, the Minnesota Medicaid waiver is not, which we bill to for these services with billing codes, doesn't allow us to bill for internet. Go figure. That's a gap right there that should be addressed. Not sure that's in the confines and purview of this group, but there's a disconnect. If you pay for the entire system, and the system has to have connectivity to work, but you don't pay for the connectivity. That's a bigger issue that Medicaid waivers don't pay for that.
Thank you. Any last questions for Ron or Steve? Well, thank you, John.
Last thing I'll say, Teddy, is I think Anna or Bree, will there be an opportunity to circulate this deck afterwards, okay? Teddy challenged me when we put out the invite to come to this meeting, that this is a working group. This is a group that is busy, but they come here and dedicate time and resources to roll up their sleeves and participate in this really important initiative. And they asked me to say, what are you asking us to do? Okay, there's one ask, which is we'll talk about, which is to increase and some visibility at the executive branch level of. We've had some exposure, but I think they need to hear and see this story in the office of the governor. And then lastly, I would challenge everyone in this room and those that are online. If this seems impactful and meaningful to you, could you take one step, do one thing on our behalf? And it would be one of the things in those 3 categories of either engage directly, help connect us to others that would may be interested in this, or help amplify our message. That is our ask. And again, everyone is extremely busy and is going to leave this meeting and go off to an extremely balance of a busy day and travel, etc. But if this resonates with you, would we'd be happy to follow up with you, engage in further conversation, whether it be your organization or your company, or one of the other options of connecting or helping amplify. We really, really appreciate it.
Perfect. Thank you. And I appreciate you following up on that ask, because I think this is really helpful, and I definitely have it down in my notes there as well. And Steve, thank you for the presentation. I think that was really good. Okay, we will adjust the schedule. One of the things that wasn't going to work out really well anyway was the subgroup meeting time, so I will assume that you will meet. I encourage all the subgroups to meet, before the next meeting, and then the next meeting will definitely put a lot more time to starting to work on recommendations and reconciling those and coming up with a report. But so skipping that piece, the last piece we have left is really just an update from the Office of Broadband Development and some of the latest activities with BEAD. So, Bree, I'll turn it over to you and the team for that update before we wrap up.
Dave for hosting us and guests for being here. First, I believe Devin is online, but as you recall, Dariel Dannon left the team of DEED, our legislative, and we have Devin Bowdry back, if he looks familiar to you. And so I was just going to give Devin a quick minute to say hello and his work here with the team.
Hi, everybody. Thank you, Bree. Yeah, I am back. I don't think I was even away for a year. I think it's maybe 5 days and to the point where it'd be a year away from DEED. Just can't resist. I love DEED, love broadband. Not sure if I'll be covering broadband fully. I'm still kind of getting reacclimated, seeing where my team has been at, and we'll figure out who will cover broadband coming up. But happy to jump in and chat with this group at any point in time. I've enjoyed working with you all for the last, I don't know how many years, 4 years, 5 years. So any questions you have, feel free to reach out to me, and happy to help out. Good to see you all.
Welcome back. Glad to have you back.
And then the other thing I was just going to point out is we have quite a few members of my team as we've been growing in person today. So some, Diane and Carol, but others, Samantha, well, Anna very well now too. Samantha and Ace and Ben, who have joined our team. And I'm not sure if anyone else online, but hopefully getting to know them in person and them getting to know all of you and the work and how our work impacts Minnesota is a great opportunity for them to be here. And they just wanted the butter, Dave. Like I said, butter. Just kidding. So anyways, one of the things we're working on just as the office and having Devin listen in here is it's already that time to start looking at agency requests to the governor in the next legislative session. So I won't go into details, but a lot of what you all are having conversations on certainly aligns with what we're going to need moving forward, and happy to meet with subgroups as well. So know that work is already happening. To that regard, with the staff team, we do have a new staff person joining tomorrow, so continuing to meet the needs of all the work we're doing. I'm going to skip a little bit and go back to BEAD with Diane here and jump into just some other office things we're working on. So I think we've mentioned this before, but are working on an RFP for a cost to serve. So a couple years ago, when the taskforce, for those of you who were here, in 2022, I think was the last official report, there was an estimate of what it would cost to serve all Minnesotans at that time, unserved or underserved. And it was like $1.6 billion. We haven't done that, and so one of the things with our dollars is knowing, so that we have data to really understand what that cost would look like in the state of Minnesota on top of BEAD. And again, we define what and underserved looks a little differently than what the BEAD dollars are going to bring. So we're working on that, and hopefully we'll have some data that we can also provide the task force for the next legislative session. And then I know everybody is anxiously waiting round 10. We are finalizing those grant applications, but I think I reported last month we had over $126 million and requests for $50 million for both low population and border to border. So it's very good applications, extremely good applications, especially our low population, but it's just extremely competitive and limited funds. I already updated on the line extension, but I also just want to point out the team behind me and many online folks not able to be in attendance have been doing site visits. So as a reminder, we go out and we look at every site before completion and during progress of those locations to make sure they are built to what their grant award has stated that they will do so. So a lot of compliance issues we are already doing, but more will be coming with the next round. Some of the legislative changes, so trying to be on top of all of that. I'm going to turn it over. I'll just quickly, digital equity and capacity grant. So I did clarify the difference between the competitive grant. As the capacity, we are still waiting. We are hopeful that we're in this next batch of NTIA approvals. I believe there's only 3 states across the nation that have their capacity grants approved. And as a reminder, our funding to support the staff that we have ran out at the end of March. So talk about an equity issue. We're supporting our great staff as we continue to keep that capacity growing in the state. But we're waiting. And so that's where that particular capacity or digital equity work is at this point. Just really quick on the volumes. A lot of our team was in Portland last week with the State Broadband Leaders Network, which is hosted by NTIA, to learn all of the new that continue to evolve with the program. But while I was out there, was able to visit with Assistant Secretary Secretary Alan Davison, and our volume 2 should be in the approval process or approved at any second. So we are all done. One of the things that came up very last minute, and actually while I was out there, is an agreement that the 49ers and NTA and many of our members had in the legislative session to form a contractor list, a good contractor list that providers would use. NTIA was not accepting of the provider choosing contractors within the state joining us and in the state. So up to 50% of the contractors they hire, which we reached out to our labor partners to share that and really try to be transparent that we tried really hard. And I think Diane and I have been very upfront. We've tried really hard in the BEAD process to be very transparent, but also mirror that as a legislative directive as close to borders we can. It looks vastly different. But we are hosting webinars right now with all types of providers, so the 4 different types of ISPs we have in the state, to walk through what we know the volume to look like right now, and probably approved, so that we are managing their expectations, answering questions, gathering concerns, and just trying to best mitigate participation in the program as we move forward. So I'll let Diane add to all of that fun.
So we are also in the middle of the BEAD challenge process, and that is to establish that final list of locations that are going to be eligible for BEAD funding. So the challenge 30 days is over. The rebuttal 30 days will end next Monday, and then we'll go into adjudication. And from that, we will have the final list of BEAD eligible locations, with the understanding that there will be ongoing deduplication as we announce our round 10 line extension round 3. We've got several Minnesota providers that have pending U.S. Department of Ag Reconnect and Community Connect grants that they're waiting word from. So if you're funded with one of those federal programs, your location, then it will come out of that final list of BEAD eligible locations. And then we're also working with Connected Nation to do the major update to our maps this fall, and we're going to try to capture construction that's occurred this year and try to get that deduplicated off that final list. So we should be able to send that final list of what we feel are the BEAD eligible locations to NTIA for their approval We hope by December. And then we think it'll take a couple of months for them to approve it, which would put us into February, March. Then we can start the subgrantee selection process. The volume 2 approval, which seems imminent, will start that 365-day clock for us to select all subgrantees, but we really can't do that until we know what locations are eligible. So there's going to be some months delay. We're also looking at a grant management system that will help us process this large volume of money, the number of projects, the number of locations. So the portal's going to look at a little differently than it did for round 9 and 10 when we get this set up. But hopefully it'll make it much easier for us to feed the data to NTIA once it's collected from subgrantees, so it flows smoother. And we hope to have that system up before we're anticipating doing a pre-qualification process. Given our window to do 3 subgrantee selection rounds is getting so squeezed, if we can pre-qualify providers that want to participate, then they'll know they're good to go. Financially, technically, managerial, and operationally, they've kind of met those gating criteria, and they're eligible to submit applications for specific projects. So if we can push that gating criteria ahead of the subgrantee selection, it'll save us some time. So those are things that are all kind of in the works on BEAD.
Just a couple quick other things along those lines is, one, as you can imagine, we are pushing our internal legal team a lot with legal questions, and how things can be awarded, if we could do how we can do our subgrantee selection, how we can do grant agreements, all of those things. So there is an extra burden within our internal folks at DEED. And then the other thing is, as we all know, probably have all heard, permitting and environmental reviews are challenging even right now with our partner agencies, whether it's because of workforce or clarifications. We are working really hard to do that at the administrative level, to really understand where those barriers are at and try to, we do have funding within BEAD to help support that, and if we need to do so because these volumes are going to be large for about 2 years. So what does that look like, and making sure that we are able to streamline those processes. For those of you unaware, sometimes a grant, they could rattle off. Now we're going through DLI, Department of Commerce, DNR, MnDOT, MIAC, which is the Minnesota Indian Affairs, OSA, which is a state archaeologist, SHPO, all of those agencies in order to get the clearance to be able to broadband infrastructure. And so knowing that all of us have a role in that, and where we can, like I said, mitigate some ways of streamlining it, we're trying to. That's what I have, unless there's questions.
Questions for Bree and the team? Mark?
Question, you talked about site visits going out and looking at compliance. With no specifics, of course, have you had compliance issues to much degree at all?
Not that have been flagged for me. I know at times there may not be locations that they were missed for inadvertently or for whatever reason it is, but then the grants are adjusted based on that.
We always withhold the last 10% of the funding until there's a field validation visit with speed testing. So in about 3 instances, there might have been a road missed from a project. You have to understand, the providers are doing a lot of their own private investment, or they might have multiple funding sources for projects and they just missed a street. So we catch that, and then they build it before they get that last 10%. We've had a couple of instances where when the speed testing has been conducted, the speeds haven't been there and it's not rolling over to the next fiber like when it's at capacity. And so it's generally helpful to the providers to know that there was a little glitch in how they had something set up. So that's happened a couple of times. So.
Thank you.
Other questions online? All right. Not hearing any. So, last piece is any other business that we need to discuss. Anybody else want to bring up anything to the task force? Okay, not hearing anything here. One of the things what I'll say is for the next two meetings, October and November, most likely will be in St. Paul. And the focus will heavily be kind of working on the recommendations and the reports. We may have a presentation here and there, but in general, it's trying to be able to get together. So if you're able to make it in person, that's great. I understand if you're not able to make it in person, but we'll probably spend a lot of time trying to kind of put our heads together on the challenges, the recommendations, what information do we need from OBD as far as even some of the pieces Bree mentioned, put that all together and then be in a situation where we can have a report done by December. And as you heard from the senator earlier, the sooner we can get it to him and the other legislators ahead of the legislative session, that helps them form their thinking and implement some of these, or at least suggest some of these recommendations that we'll put forward. So that's the plan for the next 2 months. And I really thank everybody for their participation today. I think both PCs for People and Healthy Med for coming in today and doing the demonstrations. I think there's some really good work happening there, and you really demonstrate why we need broadband in all communities. I think that's pretty clear, so that's exciting, and also gives us good ammunition to make some of these key recommendations, and it's good to have some of the legislators on as well. So with that, thanks everybody. Enjoy the fall, and then we'll see you deep in the fall, hopefully not winter, right, next time we meet. So thanks everyone.
Thanks, Dave.